give you an overview of the rationale for LAA occlusion in atrial fibrillation based on the Bern registry on LAA occlusion with some follow-up, of course, concentrating on the residual leaks and thrombus in connection with strokes. And maybe I can have my questions here at the beginning. First question is, what would be your initial treatment of an identified device thrombus? We've had that already in the prior speakers, so nothing, wait, perform TE 1 month later, treat with antiplatelets, treat with NOAC. Fibrinolysis is also an option that has not come up yet. Rappa has already asked the same question, Samir has asked the same question. Let's see what you've learned from them. So treat with NOAC, that seems to be the standard. Or, of course, vitamin K antagonist was not in here, but it's also an option. The next question maybe. How would you monitor for thrombus and leaks? At every follow-up, clinical follow-up, do they need a TE? Nina has a bit argued in favor of following at least the ones that you're worried about only initially after the implantation. Once in a later follow-up, I do not monitor for leaks and thrombus. Okay. So once is also what we foster. So, of course, then if you see a leak or thrombus, you'll have to maybe add another follow-up. And the third question is a bit going back to what Samir just showed. Treatment of an uncovered LAA lobe or really a big time leak, resumption of anticoagulation. Of course, here vitamin K should also be an option. Double antiplatelet therapy, triple therapy, I think it should really be out of the question. It's too dangerous. Second device implantation, Samir has shown some cases. Repeat TE, hope for a miracle. It's not going to change in 6 months. But wait and see is always an option that a lot of people adopt. Okay. Get the answer. Okay, second device implant. Samir seems to have convinced people that this is what you should do. Now, next slide, please. So the LAO registry of Bern is looking here only at 210 patients with a follow-up. We have about 300 some. I think we have that one slide earlier. We have about 300 patients that are in the registry, but we only look at those with a follow-up. And you see the reason for doing LAA closure is very varied and somewhat different to what Apostolo showed this morning. But in terms of bleeding is the most common reason still for opting for LAA closure rather than just continuing oral anticoagulation. Baseline criteria of these 210 out of 332 ACP patients that we had by March 2014 in Bern is the gender distribution is a typical one. And before LAA closure, some had warfarin, not quite half of them, somewhere on aspirin and somewhere on tynopyridine. And you can see that paroxysmal atrial fibrillation was quite prevalent with 45%, and there were a few who never had atrial fibrillation. We also already closed some LAAs as primary prevention. I cannot go into that topic right now. The technique which we have practiced now for 12 years with Amplatzer LAA closure in Bern has never changed. We started in 2002 without thinking of echocardiographic guidance and have never adopted it since, and it works quite well with fluoroscopy alone. You can see here the transeptal puncture can be done on the fluoroscopic guidance. Then you can assess the size of the LAA, you can control implantation. Like we've seen in the cases just shown, basically look at the angio much more than at the echo. And if you don't have it, of course, there's no way of looking at the echo. Final implantation, and if we go through the PFO. In some cases, the angle is really not good, and when you find that out, we close the PFO and then we puncture below the PFO closure device, which shows you exactly where you have to puncture. Now, as you can see here, that the amulet was only in a minority of cases, and you can see the risk score, a mean score of about 4, so pretty risky patients, or at least as risky as those in the rivaroxaban trial, and the Hesplet score was about 3. We like to combine things if patients need several interventions. Almost everybody needs a coronary angiogram unless they already had one. At this age, you want to know about the coronary status, so we combine that very commonly. If they need PCI, we combine it. As I said, we always go through the PFO, and if we can do it through the PFO, we close it. If we cannot do it through the PFO, we close it anyhow and then puncture below the PFO device. And of course, there were other combinations as pertinent. The outcome, of course, a little bit influenced by the combination. You have some complications that may not be necessarily due to the LAA closure, but just looking at the technically successful LAA closure, even without echo, you can have quite a good success rate, and we exclude no patients. We have never excluded any patient from an attempt based on any imaging. We don't do CT before or anything, but every patient gets attempted, so the success rate is quite good. Of course, the complications, some of them due to LA closure, some may be due to other parts of the intervention, but pericardial effusion is a threat. Tamponade, you're just lucky if it doesn't happen with pericardial effusion. It's always a threat. Device embolization in 1%, and stroke is one of the problems. Major stroke was only one case in that series. No mortality. The follow-up available with the TEE at an average of 4.4 months. You can see what the patients were on at that time. You see some were still on warfarin, but a very small group, and we never start warfarin after the intervention. I think with one or two exceptions, people who had another reason, pulmonary embolism or something, for warfarin, but very rare. But so at 4 months, practically nobody was on warfarin. Most were still on an aspirin, but we also stop aspirin if they have no other indications for aspirin after this follow-up TEE, and some were on a combination of antiplatelet therapy. Late device embolization did not occur. I cannot conceivably think of how it should occur. I think if it's still there, once the patient is ambulating, the one critical moment is the first time the patient gets up or turns from his back to his left side, because then the device bumps against the pericardium for the first time. This may be the last moment it's going to embolize. Once they've done that, I'm sure there will be no late embolization. You may detect it late, but the embolization will have occurred earlier. Late bleeding into the pericardium occurred in a few cases, which is usually more a reactive thing than an erosion, I think, because the blood is usually quite thin, so it's more kind of an inflammation reaction. And other reasons for hospitalization, as you can see, in 3%. Residual leak, as you can see here in another example with an ACP, of course, do occur, and we usually also call those larger than 5 millimeters significant, although we do not do much about them. It needs to be a big residual leak before putting in a second device, and Apostolos has shown that in the larger series, usually the threshold is 3 millimeters. You can see that 11 cases, 5% did have a residual leak, and complete occlusion was in the remainder. And what you can see here, that most residual leaks were small, less than 5 millimeters, and only 3 had a residual leak of larger, and 1 actually had never received the device, but is still in the series. So, of course, this is the largest residual leak that you can have if they never had a device. 2 patients with a significant leak and the thrombus. So this is, of course, a lysine fleas, which you certainly don't want, and maybe there is a connection, maybe not. I don't personally think there is one. They went on to oral anticoagulation. 1 thrombus resolved after 2 at 3 months, and 1 didn't. So this one was continued on oral anticoagulation. And 1 patient did not get a device. So, of course, this residual leak is kind of a non-treatment. No neurological sequelae in any of the patients with residual leaks or a thrombus. Here is a case with a thrombus. This is more than just tissue filling because it is a little bit moving in the flow. If it's not moving, we might just not consider it dangerous, but if it's leaping into the left atrium, moving, it might be dangerous. So thrombus non-mobile were seen in 10 patients, 5%, and the mobile thrombus, just 2 patients, which is 1%. It's not a very common thing, in spite of the fact that we never use oral anticoagulation after the intervention unless there is a special reason for it. And you can see that of those 12, most 9 were started on oral anticoagulation, but not everybody, because some of the non-mobile thrombi we just accepted and didn't do anything. 3 patients with thrombi also had a residual leak, so that's the worst group with both blemishes, and you can see that 1 out of 7 patients that were restarted in oral anticoagulation had an intracranial bleeding. So that shows that the oral anticoagulation is not a benign thing, and you should think twice before you put something back on that you, for some reason, put something in the LAA because you were worried about bleeding. Neurological events, just 2 patients with procedural neurological events, one that was a real stroke, and 1 post-procedural stroke, but none with permanent sequelae, but that's just lucky because you cannot govern that. Okay, there was this one late stroke, 280 days post-LAA occlusion with full recovery. And this is this particular case where you see this thrombus doesn't look so dangerous, but perhaps the dangerous part had already gone away by the time we diagnosed the stroke and looked at the TE again, and after a few months of oral anticoagulation, it had cleaned out a little bit. So residual flow thrombus formation in other studies, surgical LAA closure, we've heard about that. It's not always perfect, although they probably could do it better. Now that we are breathing down their necks with a competitive device, they are doing a better job than they did when they had no competition, for sure. But residual leaks are 72%, of course, is a sloppy surgery, but even if they try to be complete, they are not always complete. ACP registry, we heard about Apostolos this morning. It's going to be published, so there was no correlation with residual leak or thrombus and further events, but this may be a type A error, not enough cases to really prove that they are not dangerous. The same thing with PROTECT AF, as we've just heard from several groups. Nina also said that the 33% do have a residual leak. Now we heard from PRAPA it's maybe only 28%, but it's a high level, and that there is no association with further events, as we've seen in that picture we just saw also from Samir, maybe a type A error. So maybe it is still a little threat, but the threat doesn't seem to be worthwhile to worry too much about it. Thank you.